Okay. Well, good evening, everyone. We're delighted to have you here. Thank you so much for attending AONM's first webinar in a series that will be continuing throughout the year. We're delighted to have Professor Pachmann, Katharina Pachmann, from the maintrag laboratory in Bayreuth, Germany, with us this evening. I'll just introduce her briefly. She received her PhD in Munich in 1994 and then continued working as the head of department of experimental hematology and oncology there at the University of Munich for many years, and then moved to MD Anderson in Houston, Texas, where she learned to work with a new microscope that was able to detect very rare cells. And she and her team started to track cells being shed from tumors into the bloodstream and found that they could monitor the activity of solid tumors throughout the entire course of disease. So when she moved back to Europe and was awarded a professorship after working at the University of Jena, she continued refining the technique and now runs the maintrag laboratory in Germany with a staff of 45. So over to you, Professor Pachmann. Thank you very much.
Gillian just mentioned about questions.
Yes, well, we'll be very, very glad to answer questions in the Q&A at the end, in the final 20 or 15 minutes. And so please click on the square at the bottom, which is called chat, and you'll find that you have a little panel on the right where you can write your questions, and just press the return button on your computer and the question will appear, and we will make sure that Katharina answers it at the end. And if she doesn't have time for all of them, then we will send around the answers to the questions later. And the webinar is also being recorded, so we will make it available at a later date for you to watch again if you'd like to. Thank you.
So, hello, I'm Katharina Pachmann, and I would like to talk today about the science and clinical utility of circulating tumor cells as a tool to monitor the effectiveness of therapy. Well, malignant tumors are detectable when they have reached a size of about 1 centimeter, and the first therapy is usually complete surgical removal of the tumor. And then patients are often declared cancer-free, but more cautious advice is to wait for 5 years relapse-free survival before such assurances are given. How do the metastases develop, which can occur even after a complete removal, a surgical removal of the tumor? Cells can break away from tumors during tumor growth, and it's these cells that are responsible for distant metastases, even after resection. Such metastases can occur in 25 to 50% of cases after successful surgery, most frequently in vital organs like liver, lungs, and bone marrow. It takes quite some time until such metastases can be detected in a fast-growing tumor with a doubling time of about 36 days from one cell when the tumor was from a mutated cell grows to detectability. It can take 3 years. And when this tumor has grown to detectability, it has about 1 billion cells. And if only one of these cells, which is still undetectable after surgery, is able to settle in a remote niche or sanctuary, it will take about, again, 3 years for this cell to become detectable. And that's an experience which has been made, that fast-growing tumors take about 3 years until metastases are detectable. With a slow-growing tumor, which may take 10 years from one cell to grow to 1 billion cells, a metastasis will be detectable after surgery about 10 years later. And that's also an experience which is made clinically. The cells can break away from the tumors from a moment when vascularization begins. And that's at a size of about 1 millimeter, that's 1 million cells. And together with the nutrition, cell can be shed together with tumor debris into the circulation. So seeding starts from the moment of vascularization. And since carcinomas are of epithelial origin, they disseminate epithelial cells, which we call not just CTCs, but CETCs, circulating epithelial tumor cells. And even if 99.9% of the shed cells die, the number of cells remaining in the circulation over time adds up to several million cells. And the debris from the tumor can also comprise DNA from the dying cells. So our method for detecting tumor cells we have called maintrag, and we try to find only living cells. How does this work? Okay, we have the circulating epithelial tumor cells have on their surface structures, antigens, which is, and one of these antigens is called human epithelial antigen, or EpCAM, and we have an antibody against this surface structure, and this antibody is fluorochrome labeled, and it binds to the structure and makes the cell visible. We do not use fixation, isolation, or enrichment. The procedure is shown here. So when the blood sample arrives at our laboratory, the red blood cells will be lysed, and the remaining cells, as you can see, are stained with the antibody, and only the epithelial cells will stain, and the normal blood cells will remain unstained. We then add the cells to a 69 well plate and put it under the microscope, which detects the cells for us. And that's a typical picture what the microscope shows us. And then we can form with several analyses a trajectory of the cell count, and this can be used to monitor whether a therapy is effective. Here again, to show the heterogeneity of the cells from, for example, one patient. On the right side, that's the cells which are alive, and you can see how diverse the staining of these cells is, and some of the cells have only very tiny staining, and it is assumed that these cells may have downregulated their EpCAM, but still there's a little bit visible, and this may be the most important ones, which on the other hand may be lost in other methods. And in addition, we distinguish between dead and live cells, because the dead cells will have a red stained nucleus. Their membrane has become permeable, and the red stain can enter the nucleus, and thus we can distinguish between living and dead cells. The number of these tumor cells as compared to the other cells in blood is shown here. So it's 4.6 8.5 billion red blood cells, 4 to 11 million white blood cells, and our limit of detection is 10 tumor cells, and it can add up to a higher number. I would just like to shortly compare our procedure with other methods. So the most otherwise known is the cell search method, which uses magnetic bead enrichment to look for these cells. And as you have seen, the EpCAM can be very low expressed, and it's the question whether this expression is sufficient for enrichment. It's known that this method loses a lot of cells with low antigen expression. Other procedures are microfiltration, which look for cells that are larger than blood cells, because tumor cells are assumed to be larger than the blood cells. But we know that there can be also small tumor cells, and they are lost by this method. Another method is negative depletion, which is used in the RGCC method. And there you remove the blood cells, which are known to be CD45 positive, but tumor cells also can, in some cases, express this CD45, and they will be lost, so the results can be false negative. And there's another method using micropoles, but there are technical problems in part with this method. Another very common method at the moment is looking for circulating tumor DNA, ctDNA. It's isolated from plasma, and it is DNA not from living cells, but from destroyed cells. And the question is, how stable is this DNA in the plasma? And we know that during shedding of DNA, additional mutations can occur during the DNA degradation. So there may be mutations detected which are not present in the living cells. Our method is fully accredited by ILAC and the German DAKKS. I would like now to go into how we can monitor therapy using these cells. And the first step, as I mentioned before, is surgery. And what we detected during surgery of breast cancer, that is that before surgery, we set the number of cells detected as 100%. And what occurs is there's an increase in cells after surgery. So this is 7 to 14 days after surgery. And there was an increase. And in some cases, subsequently, there was a re-decrease. But in some cases, cell numbers remain elevated. In this case, we didn't monitor the cells longer than 40 days because usually at that time in conventional therapy, there is the adjuvant chemotherapy following. But it should be emphasized that cells very often are released after surgery, and the same is true for lung cancer, and we have also seen a lot of release in surgery of colon cancer. In addition to releasing cells, surgery also can lead to activation of cells. So these are molecular analysis of cells before surgery and after surgery. And what we did is, what each cell is one of these lanes, and we did an molecular analysis of different genes, expression of these genes before and after surgery. And as you can see, after surgery, before surgery, most of the cells are very low expressing. They are sleeping, but they are activated. All of the cells looked at after surgery have a more activated status. And most importantly, this cell, for example, expresses a stem cell gene, NANOC, which may signal that this cell has acquired stem cell properties. And these two cells have started to express vimentin, which is a gene that allows the cells to attach to the membrane or to the endothelium of the blood vessels, which may help the cell to settle, and then it can start growing into metastases. One of the treatments which has been very much favored at the moment is the so-called neoadjuvant treatment. That means the patients are treated with chemotherapy before surgery. The advantage is you can see how the tumor shrinks, and this is a positive experience for the patients. But what we could see that is that in the beginning we see a decrease in the circulating tumor cells. Each of these trajectories is one patient, and then subsequently, when the tumor shrinks, cells are seeded into the circulation. So we find an increase of CETCs during shrinkage of the tumor. So increasing numbers of CTCs may be due to release of cells during shrinkage of the tumor, in addition to cell death. And that's an example how we assume the tumor is shrinking, but more and more cells are seeded into blood, which then one of them might form, grow into metastasis. And this is an example of a patient. So there was this decrease, an increase during the shrinkage of the tumor, surgery, and half a year later, the patient already showed a relapse in spite of further therapy. And this is a so-called Kaplan-Meyer survival, where here all patients are still alive, and each tick down is one patient suffering relapse. And as you can see, those with increasing cell numbers had a faster relapses than those with decreasing cell numbers. So if cell numbers increase during neoadjuvant treatment, they have a poorer prognosis than those with decreasing cell numbers during neoadjuvant chemotherapy. We can also test for different agents for the toxicity against the patient's own cancer cells. So you can send selections of the agents you want to test, and you can also select from our list of suggestions drugs or agents that are supposed to kill the cells, and we can test this agent most often as an infusion, but also as an oral supplement. But the results may be different because orally the agents need to transgress the bowel and then get into the blood. We can also test mixtures of formulas, and you can choose the combination. This is the drugs, conventional drugs, which we can test, and we can also test other substances which you want to be tested. And this is an example where we tested. This is the number of cells which we found, and different drugs or different agents. And in this case, capecitabine was the most effective one. We also can test natural agents. Here is a list of agents which we can provide, and further substances you can send us, and you can also ask for combination testing. This is the effectivity which we have tested for vitamin C. This was 30 grams of vitamin C, and you can see that there are patients who do not respond, but also quite a number. It's 45%, which have 45% which have a good response to vitamin C. Artesunate tested even better in our hands with a higher fraction of patients who test sensitive more than 60%, which we would consider to be effective. And even better is curcumin, which tests effective in 75% of patients. This is a report like you receive it then, and here are the different agents and how effective they test in this special patient. You can then see that in these patients, and that's very frequent, that natural agents seem to be more effective than the conventional drugs. Most effective in our hands are, in fact, curcumin and, for example, also artesunate. We can also test combinations, like here, curcumin plus hypericin, and it was 85% effective in this case. We can also test and show you that different concentrations are differently effective. For example, here is an agent which is very effective at all three concentrations. One-fold is the concentration which we usually assume is achieved in the blood. Also, different agent reactivities to vitamin C, 30 gram, artesunate, and you see here with a 0.1 fold, it's very low, but then it increases highly up to here. Curcumin, in this case, we only could got results for one concentration, but it's very effective at the concentration of 450 milligrams in blood. And this is a trajectory of cell numbers, how they develop under different treatments, where you can see if one drug is administered, how the cell numbers decrease. They can then re-increase, and upon the next treatment, they again re-decrease. So we can show how cells respond to the treatment in a trajectory of cell numbers. We also can test maintenance therapy. And I would like to emphasize that all these analyses are performed in patients with a primary tumor, not with the metastatic tumor. So I think that's most of the patients who asked for your help are patients after they have been treated for the primary tumor and then come and ask for help during the further course of disease. This is an example of Tamoxifen therapy, and here we could show that patients who have decreasing cell numbers or stable cell numbers under this endocrine treatment have a very good prognosis, whereas patients where they show increasing cell numbers during this endocrine therapy suffer relapse. So if we find an increase in cell numbers during therapy, the endocrine therapy with tamoxifen, we would suggest to change the treatment. And in this is shown here. So if we look for the cell count like every 3 months and we find an increase, we would suggest to take change in therapy into consideration. And in this case, for example, it would be aromatase inhibitors or natural agents. If we see a decrease in cell numbers, you can go ahead with the same therapy. But the next problem for the patients in breast cancer, for example, is that after 5 years of treatment, it's suggested they stop their endocrine therapy. And then the patients are left without any treatment. And it has been shown that if the patients stop the endocrine therapy after 5 years, there's a 32% of relapses during the next 10 to 15 years. If they go ahead with 10 years of treatment, which the patients don't like, they already are longing for stopping to the endocrine treatment. But if they go ahead, they have 28% of relapses. So that's a significant but low difference. What we can do is we can monitor these patients not only during the endocrine treatment, but even after stopping treatment. And this patient, for example, had the same number of cells even after she had stopped the endocrine treatment. And this means she has a good prognosis and can go ahead without any endocrine treatment. But this patient, for example, after stopping tamoxifen, she showed an increase in cell numbers, and shortly after this increase, relapse was diagnosed. So if we find an increase in cell numbers after the end of, for example, endocrine maintenance, we would suggest to restart endocrine treatment. But those who have the stable numbers, they can forego further endocrine treatment. So this is the results. Patients with stable or decreasing cell numbers have a good prognosis, and only those with increasing cell numbers, we would suggest that they restart endocrine treatment because they are at increased risk of recurrence. A very complicated situation is metastatic disease, because in metastatic disease, usually systemic therapy is started to reduce the size of the solid masses. But in this situation, it's a little bit like neoadjuvant treatment. There's an interaction between the tumor and the blood, and there can be changes in numbers due to elimination, but cells can also re-enter existing metastases. It's called reseeding, and then they disappear from the blood and we can't find them anymore. So if the cells in the blood respond with a decrease, but the metastases grow, then it may be that sufficient concentration of the drugs are reached in the blood, but not inside the solid masses, because there is a high intratumoral pressure. And this is the most frequent cause of treatment failure in metastatic disease. An increase in circulating cell numbers can be due to release of these cells in addition to cell death, like in the neoadjuvant situation. This is an example of a metastatic breast cancer, and she had an increase in cell numbers, but at that time she got immune therapy, and as you can see, her cell numbers went down nicely. But we also tested for this surface antigen called PD-L1. This is the expression of an antigen which allows the tumor cells to silence the immune system. And as you can see nicely, that this expression went down, but it's starting coming up again. So this patient was at risk of relapse again, and she then started again immune therapy. So we could help her and tell her it's better to restart, and she's still without relapse or without progression at the moment. So when you want to monitor your patients, you can send your samples via AONM to our center, and you will get the results in about 5 days after we have received the sample. The sample should arrive at our place between 40 to 72 hours, and it should be, that's very important, be kept at room temperature. For this purpose, we have now developed shipping boxes to allow the sample arrive at an optimal temperature at our laboratory. And you will get the results about 5 days after we have received the sample. And this is our laboratory. And for information, please go to AONM in the UK. Thank you very much. So, Gillian and
hello again. Thank you very, very much, Professor Pachmann, for that fascinating presentation. That was a very concise but comprehensive overview. One term that you used, which was 85% effective, for example, for artesunate. I just wondered whether you could explain to us what that word effective there means. How long are you testing for, and what's actually happening?
Okay, so we expose the cells of individual patients in the same way we count the cells, but then at that time we expose the cells to the agents for 3 to 9 hours and look for the decay of cells when they are exposed to the agents. And usually we take 6 hours exposure and measure how many of the cells have died during this period. And if in this case it would have been 85% of the patient's tumor cells that have been dying during this time, and that's what we report.
Okay, thank you. Would you like to switch yourself to full screen so that we can see you? We will be making the slides available to any of the participants who'd like them. It's not essential, but if you can, that's great.
Okay.
Thank you. Another question, please, is this method suitable for all types of cancer?
Well, cancer, if you mean the term in epithelial cell proliferation, which cancer means, yes. It's more difficult with, for example, sarcomas, okay. Because they only have a part, or often only have a part of cells which express epithelial antigen, and it's not cannot be used for leukemia at the moment, okay. Because our approach is to distinguish the epithelial cells in blood from the blood cells. But leukemic cells are blood cells. But there are other ways to monitor leukemia, which is not our approach.
Okay, thank you. And another question is my oncologist or my patient's oncologist likely to accept these results? I mean, we're talking about 3 different kinds of results here, the CTCs, the chemosensitivity, and the drug or the agent sensitivity. What's your experience been in Germany?
Whether they like to, or whether the oncologists, the conventional oncologists, well, it's increasingly accepted.
Really?
So, well, we can show that and we did show it in conventional drugs, mm-hmm. that it was highly correlated when the cells respond to the therapy in vitro, that it's also effective in the patient. So increasingly these analyses are accepted.
Thank you. Yes, you've done very long-term studies, haven't you, which is very unique, I think. What's the longest study you've done?
Yes, I think we are the ones which have the longest experience, and it's up to more than 10 years in some patients.
Okay, thank you.
Which means the same patients have been faring well with the treatment for more than 10 years.
Right. One question that's come in that I'd like to ask here is, what form of curcumin is the most effective? You showed very high percentages there for curcumin.
Yeah. Well, there is a curcumin which is produced from the Burg Apotheke, which the problem with curcumin is to make it soluble because it's insoluble in buffer, so you have to make it soluble, and to solubilize it you need something in addition. But I would not like to prioritize any of the formulations so far. I think we need to test the formulation you would like to have, and then we can tell you whether it's effective in your patient or not.
And what's interesting is we can mix them, can't we? We can say we'd like to use 50% of this and 50% of that.
Sure,
that's what's traditionally been used in my clinic. Send that in and see what your specific results are for a particular patient. It's very personalized.
Yes, it is. So you cannot draw the results from one patient to the other. It needs to be tested in each patient individually.
Okay, thank you. One question relating to the curcumin has come in that's rather long and specific to a particular patient case. So would it be all right if we send in that question to you afterwards and request that you return a detailed reply to that particular?
Yes, I will.
Thank you very much indeed. Another question here is how one actually takes the blood, does it have to be frozen?
No, that's very, very important. And I try to emphasize that
Mm-hmm.
it has to be kept at ambient temperature. So it's between like 11 and 18 degrees, and not freeze it down, because the cells will be destroyed by freezing.
Okay. Well, you mentioned that there is a specific kit that you now use worldwide, and that keeps
it's
it
a box
at the
where
right
you
temperature. Yeah.
Yes. Did we supply it to you, Gillian?
Yes, absolutely.
Yeah.
Yeah.
So
in terms of the number of CTCs, this is a question that all therapists ask, especially when they do the test the first time. Is there a specific number of CTCs in the cell count where, even if it's a first result, you would be worried and suggest that the patient does do imaging? Or is that always a baseline, the first count?
It's mainly a baseline. But if it's over 2,000 cells per ml, we would recommend to do something in addition. But mainly it is the dynamics of the cell count. So if it increases from the basic value to high values, then we think it's a sign of tumor activity.
Yes, especially, I suppose, if the patient has had cancer in the past.
Only if the patient,
even if they're doing it for you, with you the first time, then you would probably suggest that they do imaging if it's high.
If it's very high, yes.
Yeah.
But indeed, the most important is the difference between two measurements.
Yes, I remember you saying you don't really like to see it used as a screening
tool. No.
Both for regulatory reasons and also because that can be misleading. One question that's come in here is there an acceptable cell count? In other words, may you sometimes find circulating cancer cells and the number is acceptable and may disappear after a while?
No, we need to see. For example, if you have, if the patient has a treatment, it can go to below our detection limit due to the therapy, but there can still be cells in remote regions or in the body somewhere which can be reseeded into the circulation. So then we might find a re-increase even after effective therapy. And one really important issue is that there are sanctuaries like the brain and also the peritoneal cavity, where cells can hide and not get washed into the blood. And that's a problem, but it's the same problem for all tests. So it's difficult for these situations we might not find the comparable increase in cell numbers.
Yes, well, what's nice, I think, and that's another question here that's come up, is whether therapists who do the tests with you can have a consultation afterwards to at least discuss the results and understand them a bit better. And I know that you do offer that, don't you?
Sure.
Yeah,
everybody can call anytime or send me an email, and I will try to answer it.
So you can discuss the specifics related to the patient case.
Yes.
Yeah. Does the laboratory do sensitivity testing for vitamin B17?
We do. And it's really very much dependent on the patient's cells, whether they respond to these agents or to this agent. But there are also drugs that do not work by killing the cells. They just silence or they stop the proliferation of these cells. They may not appear like killing the cells and still work over time.
Right.
Some of these of the conventional drugs will be, for example, 5-FU, and vitamin B17 is one of the drugs which are not very effective at directly killing the cells.
That's interesting. Thank you. One can always ask you before testing whether it will be worthwhile looking at a specific agent, which is also, we would recommend that people contact AONM and ask us, because we do have a repository of frequently asked questions that we can get first.
And you always forward the questions to me if it's necessary, don't you? Yes.
Another question that's come in here is, how often after surgical removal of the tumour is the test recommended? Monthly or 6 monthly, or does it depend on the tumour itself?
It depends on the aggressivity of the tumour. Usually, if the cell numbers go down after surgery, you can do it 3 monthly. But if we find an increase, we would recommend to do it a second analysis, like 4 to 6 weeks later. And if we see a further increase, we would recommend to start a therapy or to change the therapy.
Right. Is this test only being done in Germany and now in the UK, or have other countries started using it as well?
Oh, we have requests from all over the world.
Oh, okay.
Australia is one country, but we have it from everywhere. North America, South America, everywhere.
Another question that's come in here is, what's your opinion about products or ingredients that can actually kill cancer cells? I think what is probably meant is, do you actually have a list of recommended agents? If somebody were to ask you, well, what are the most likely agents based on your statistics from the past, would you be able to let us have that?
We can recommend some, but actually most effective seen for us, or most frequently effective, are indeed curcumin and artesunate.
That's fascinating, isn't it?
Yeah. And it's an old knowledge from India that it is effective.
Right. Another question here is there a genetic, if there is a genetic history of cancer, can the test be used as a preventive measure, or is it preferable that the tumor is first diagnosed?
At the moment, we recommend we are doing studies on BRCA-positive patients in breast cancer, but still we can only recommend it for patients where the tumor has been diagnosed.
Okay.
Outside from studies.
Okay, thank you. You did mention a particular test there that showed that even though the cell numbers were falling, the particular type of cell that is able to suppress immunity was rising.
Yeah.
Is that a test that is generally available, or was that just a research test?
It's generally available. We have validated it. That's the PDL1, and it's a surface antigen on tumor cells, which is able to silence the immune system of the patient. It's known. It's known, and the immune therapy used there is these antibodies, ipilimumab and nivolumab, and more of them now available. That's the conventional antibodies which are used.
You do have a large number of tests available that we do also have on our requisition form that are a little opaque for us, like that, where we'd need a bit of explanation before ordering them. And maybe you could just highlight a couple of others. For example, if somebody has a triple negative breast cancer, that can alter over time, can't it? So I remember you explaining to me it can be worth retesting to find out whether that triple negativity has remained, for example, after an operation. What are the sorts of changes you have seen?
Well, it's not only seen by us, it's quite well known that triple negatives, where the primary tumor has no expression of estrogen and progesterone receptor and no HER2/neu expression, can change, and they can have both estrogen expression, and then it would be worthwhile to use endocrine treatment or HER2/neu expression. And this has been published by others too, and we can find this indeed, that the cells can change. And it's in about 25 to even more % of patients.
My goodness, I don't think patients get told that. Over here in England, at least. I mean, in my limited experience,
No,
for that. It would seem very worthwhile.
Yeah, it's worthwhile to test and to see, because if endocrine treatment, that's no problem. If the cells start to become HER2/neu positive, it's more of a problem, because the trastuzumab, which is used for anti-HER2/neu therapy, is not reimbursed at the moment yet by the insurances, if it's only detected on the circulating cells.
Another question that's come in here is whether the test can be done using a blood spot if the patient finds it hard to actually give blood.
No, we need to have the live cells. On blood spots, I think you could try to do a mutation analysis, but that's not available in our lab at the moment.
Okay. And can you recommend therapy depending on the results of the tests?
Yeah, like restart endocrine therapy, like doing more of therapy if it works, or change therapy if it doesn't work. What therapy the therapist decides, we can talk about it.
That's very helpful, thank you. I like the trajectory that you showed, that included the different substances that had been used. And I know you do take a very detailed history if the patient is prepared to give it, and then add the different progression. Makes it easier to see what's working and what's not. There's also another question come in asking whether there are any medicines that interfere in the interpretation of the test, causing false negative or false positive results. For example, the use of interleukins.
We have not seen such interference, because we have been testing interferon, or we have tested melanomas during interferon treatment, and there we have seen a very good correlation when the cell numbers went up in spite of interferon therapy. But otherwise, I can't recall now any interferences.
Okay. Another question here is whether the blood needs to be spun before sending it to you.
Oh, no. Keep it in the blood environment. The cells feel best if they are in their conventional environment, because as soon as we remove the cells from blood, they only survive for a short time.
Okay, thank you. Well, I would just like to mention that the Academy of Nutritional Medicine, AONM, has a helpline. The number was on that previous chart, I think the second to last chart of the presentation. And do just call there anytime if you'd like to ask about how the test needs to be conducted. It is only a very small amount of blood that's needed, isn't it? I think You really only need 1 milliliter of blood in an EDTA tube, ideally 3 milliliters, but 1 is enough, isn't it?
7 milliliters, but if you just can draw 1, we'll try to do it with 1 milliliter.
Yes, yes, I remember you saying that to me. It needs to be a bit more if you're doing the testing of natural agents. Or
of agents at all. If we need to do different agents, we need at least 7 ml.
Mm-hmm. Okay. And the turnaround time is really very fast, and then we can book a consultation with you, a brief one, to discuss the results quite quickly. You do also explain as much as you can. It's like a 2-page report that generally comes back, isn't it?
Yeah,
it gets longer as the progression is longer as well, explaining what the ups and downs might mean.
Yes.
There is another test you do, which AONM also offers, called stem track.
Yeah.
And that tests for the stem cells. You actually nurture the stem cells and see how they grow, and can then count the number in a milliliter of blood, I believe. Perhaps that would be worth covering in a future seminar. Could you just say a few words about that?
Yeah. So we think that the most important cells for metastasis, or for the Wahrscheinlichkeit, likelihood of metastasis are the cells that grow, that are able to grow. Mm-hmm. So what we can do is we can grow them in vitro in the vial and see which cells are able, in addition to being present, can also clonally expand. So this means one cell doubles and doubles and doubles again. Mm-hmm. And this we can then we can find so-called spheres. That means a group of cells which are derived and sitting together, which are derived from one mother cell. Mm-hmm. And we can count these the number of these spheres, and we have shown and published that this is correlated to metastasis formation. So if we find a higher number, then there is a higher probability that metastases can develop, and then we would recommend to start a therapy.
How long does that take?
It takes 3 weeks, because these cells take this time to grow. Mm-hmm. But if these cells can even be present without expressing the EpCAM antigen, so in some cases when we see a rapid decrease in this in EpCAM positive cells, we assume that they have changed and formed now into stem-like cells without low or without expression of EpCAM, and then we would suggest to try to grow them. And if we find a high number of clonally growing cells, we think this is a sign that these cells have changed into stem cells, and we can also show on these spheres that they have stem-like expression of antigens, and we are quite sure that these are the dangerous cells.
I think that's probably why interaction with you is so important, to get the full context. So maybe we could have a webinar with you again in the not too distant future, where you tell us a bit more about that, and also about the other options available, like the HER2/neu testing and so on that you mentioned. That was fascinating. Thank you very, very much.
Thank you very much too. So goodbye, everybody.
Thank you. Yes, I'll just mention that we do have another webinar coming up with Dr. Armin Schwarzbach, who you also know, Professor Pachmann, on the 14th of March, where he'll be talking about identifying stealth infections that may underlie ME, fibromyalgia syndrome, and other conditions. And on the 26th of March, we have Professor Craig Shimazaki from Moleculara in the USA talking about neuro-autoimmune conditions and how to test for them. and then we'll schedule another with you, if we may, a month
Thank you.
after that
You're
or so.
welcome.
And
Okay.
also, we very much hope to see you later on this year with your team over in the UK. So we'll be talking about that too. Thank you very much for everyone for taking part, and we will be making this available both as a video and the slides available to you. We'll let you know where and how to access that very soon.
Thank you.
Thank you. Bye-bye.
Bye.
Bye.